Okay, good evening, friends. Let me welcome you all to this particular session of 45th Comprehensive Course on Echocardiography. We have talked about coronary artery disease, systolic and diastolic function, and cardiomyopathy. We are going to talk about this session again in the form of live demonstrations from my echo pack, as well as a question answer session, which all of you are bound to ask anything which you have in mind, which I should be able to show by live demonstrations. With these few words, let me move on and share my slides of an echo pack where I'll be able to show a live demonstration of all these things one by one. I hope all of you can see my slides. Anyone can open your mic and show me the slides. Are you able to see the slides or not?
No, sir.
No, sir.
Okay.
No, sir.
No, sir.
Can you see it now?
Yes, sir.
Echo
Yes,
pack
sir.
machine.
Yes, sir.
All right. So I'll start with Dr. Balram. Dr. Balram, any questions, anything which you have in mind, which you like to see in a live demonstration? Balram?
Yes, sir. I would like to see measurements of how to do correct measurements of the left atrium, not just the index, but the full volume, and how you get that calculation.
Okay. What you're looking forward is, you are looking forward, how do you look for LA volume index, right?
Yes, sir.
All right. So let me just take up slides from my computer. Allow me a second.
Thank you.
So that's how you'll be able to solve so many of your questions one by one. In left atrial volume, what I need always is, I need a biplane view. In biplane view, what all I need is, I need two images at the same time. That's 4-chamber view as well as 2-chamber view or 3-chamber view. Any one of them which is available for your evaluations. So let me say how many number of images. We need number of images 2. So we have got 1 already. Let the computer take a few minutes time. Now look, we have got a 4-chamber view and a 2-chamber view at the same screen levels now. I'm going to stop it now. I'm stopping it and scroll by scroll the highest LA volume. Balram, when is the highest LA volume?
Highest LA volume is during systole, ventricular systole.
Now, in which part of the ventricular system?
End systole.
End system. So look at my cursor over here. This is the red cursor which is seen in this QRS complex. This is red cursor seen on this QRS complex. So I'm going to take this QRS complex cursor at the point of end systole. And in ECG, what is the end systole?
End systole is T wave.
End of T wave.
End of T wave, yes, sir.
Correct. So we are at the end of T wave. Now I've got both 4-chamber LA and 2-chamber LAs, right? Now I'm going to trace their area one by one. So I'm going to start with a medial annulus 1. Go along with this medial annulus. And if I'll click, now we have got area 1, that is 22.5. Now I'll go for area 2 in 2-chamber view. As we draw a line across into LV, we are going to do the same thing. Now with this area 1, area 2. Now look at this area 1, area 2, 22.3, 22.5. So there is less than 10% of a variation of area 1, area 2. Is that right? If you find more than 10% of a variation, then you have to go back and do it again. Then I have to take a distance or caliper. So I'm going to draw a line from the center of this point to the center of this LA free wall. Center of this point to center of this free wall. And we have got all the measurement at our disposal. We have got area 1, area 2, then 1 length, 2 length. And we have to take shorter of these 2 lengths. Even this also, there is not much of a variation. Look, LA is a globular structure. If LA is a globular structure, you can't find one structure on the other side is more than 10% of variations. So this is appropriately measured LA volumes. Now the formula is 0.81 into area 1 into area 2 divided by shorter of these two lengths. So it will be 0.85. Anybody has got a calculator? I'll get the calculator. Give me 1 second. You can also calculate sitting at your place of work. So let's calculate. Anybody who has calculated can let me know. Open up his mic and let me know. When I'm doing
76.15.
76.15, and normal body surface area is how much? Approximately 1.7.
Yes.
Correct? If
Yes, sir.
71.65 divided by 1.7, what will be the
44.2, sir.
perfect, Umesh? That is 44. So LA volume, which is more than 34 ml per meter body surface area, is considered as high. Is that clear, Dr. Balram?
Yes, sir. So you wouldn't look at, so do you look at the long axis just for confirmation, or?
No. Look, the most important thing is the long axis could be normal. Can I just move out of this frame? If you have any question in this frame, I'll go to long axis now.
Okay.
All right. Let me go to the slide 1 now. So I'll go to one image. And this is, okay, now I'll get rid of my colors. CFM. I'll stop it. And when I'll have the maximum area, I'll go back to the same thing, end systole. So I'm moving my cursor according to end systole. And now I can measure my dimensions. Caliper. So I can go from here to all the way to here. So how much is this one? 48. Normal is how much? Balram?
Less than 4.
Less than 4 or less than 3.9 centimeters or 40. Fair enough. So this appears to be larger. Like this could be larger and that could be normal, or this could be normal, that could be larger. Anything is possible. Why?
Because the left atrium is a globular structure.
Correct. Why it happens is initially the LA will dilate. When the LA pressure will rise, LA will dilate. Once you give LA volume will also go high. But once you give them diuretics, their LA volume start reducing, preload start reducing. Or you give them ACE inhibitor, the preload will start reducing. You may still have a little higher LA size on long axis dimensions, but it could be normal when you measure your LA volumes. So if you have a patient, this is a patient of heart failure with preservation factor, which I've showed you where. So treatment of choice according to May 2022 guidelines of heart failure, they advocate ACE inhibitor with diuretics. So initially without medical, this is the value. Once you give them ACE inhibitor with diuretics, their LA volume and their LA size may come down a little bit. All right.
Thank you.
Anything else, Balram, before I move on to the next person?
No, sir.
I'm sorry, I'm not able to get your voice.
Nothing else, sir.
Okay, great. Next time.
Sir,
Yeah.
sir, in the same topic, sir, is it the same in Mitosynosis with AF, sir?
It will
LA volume
not be valid.
Okay.
It will not be valid. It will be valid only for non-valvular.
And how to calculate in the same in valvular lesions or with
How to
AF, sir?
calculate diastolic function in valvular lesions, right?
No, LA volumes and AF,
So you
sir.
can calculate LA volumes, but
Okay.
calculation of a diastolic function in normal in valvular lesion is different altogether. Shall I show you that slide? Wait a minute. When we'll come down to your, We'll answer your question. Ask this question. Okay. Dr. Utpat,
Recording in progress.
please silence your mic. Somebody is having two mics open together. Dr.
Hello,
Umakant
sir.
Utpat,
Sir, can you show some slides of HOCM?
HOCM.
Yes, sir.
Okay. So I'll go to archive. Can you see my slides, dear? Utpat,
No, sir. It's
you can't see them?
only the initial part is there. No, nothing. Echo slides.
No, their format of PowerPoint presentation is there.
No, sir. PowerPoint is not seen.
Okay.
Yeah. Now I can see. Sir.
Yeah, I'll come back to that. This is a patient of 48 years old, 45 years old, with history of chest pain and breathlessness. Let me just show you the slides of this particular person. Oh. So this is, it'll be a little tedious, but I'll try to show you. First of all, look at this slide. I hope this does not, it's going away. What does this slide shows? Look at the septum, look at the posterior wall. The septum is almost 0.16 and the posterior wall is 1. The
Yes, sir.
septal posterior ratio is more than 1.5. Correct?
Yes, sir.
And then second, the most important thing is they have a mid-systolic MR or SAM is the second issue. Let me just try to show you the SAM. What is the next issue is here, if you'll see this, let me go to back to my presentation. I think that'll be better. Just hold on for a second. I'll go back to a different presentation. Okay. Now, this is a classical non-hypertrophic, non-obstructive hypertrophic cardiomyopathy. Look at the septum, look at the posterior wall. And when we had in a cut section, septum and posterior wall, they're almost normal. Okay. And this is a contraction, you know, like you see a granular kind of a structures, as if the granules have been deposited. and there is no MR, and there is no motion of anterior mitral leaflet towards septum
Septum.
during diastole. That flow pattern is normal: sharp acceleration time, slower deceleration time, and there is no systolic anterior motion of the mitral leaflet during diastole. This is M mode. So only is opening during diastole. Then once we come to hypertrophic cardiomyopathies, the first important feature is asymmetrical septal hypertrophy. Septum and posterior wall ratio is 1.5 is to more than 1. And the most characteristic sign is seen over here. This is diastole. This is diastole, is that right? And this is systole. In systole, you find this SAM over here. SAM. Every cycle you are able to see a SAM. And this zoomed up picture where you can see diastolic motion of the mitral leaflet, and this is classical SAM.
Yes, sir.
Next
Yeah.
comes again picture M mode with SAM. This is SAM over here. Is almost touching, the AML is almost touching the septum.
IVS.
And you have a systolic mitral regurgitation during the time when the anterior mitral leaflet should close during diastole. At the time in diastole, is systole when the mitral leaflet should close, it get opposed to septum and the mitral leaflet remains open, giving us the systolic MR in mid systolic period. So let me show us slides one by one. Sorry, somehow they are not playing. So that's how you look at the systole, and you have that MR. And on top of that, when this leaflet remains open and this leaflet goes and touches the septum, it produces dynamic LVOT obstruction. Look at the gradient of dynamic LVOT obstruction. It's almost 210 millimeters of a gradient. This is known as inverted key slope shape pattern for hypertrophic cardiomyopathy. Long acceleration time and sharper deceleration time. In contrast to aortic stenosis or aortic flow, when we have a short acceleration time and a long deceleration time. This is known as dragger, inverted key slope shape pattern, or inverted dragger shape pattern. This is the thing which I have shown. This is systolic forward flow. This is in ascending aorta. And this is hypertrophic obstructive cardiomyopathy. And this is a classical example when you see a lot of turbulence in LVOT area. And look carefully, we are having some amount of MR seen over here. Not a very classical, which you showed, but this is how the obstructive cardiomyopathy will look like when we are talking of all these things.
Yes, sir. Got it.
And most important thing in this subset of population, what will be their ECG?
LVH, sir.
And clinical presentation?
Syncopal attacks or
Syncopal attack,
Tachy-
chest pain,
tachy-
tachycardia. And when you hear them, you'll find a hard systolic murmur.
Yes.
And they're often present with hypertension.
Yes.
All right. Any other questions?
Yes. No, sir. Thank you.
Thank you. Dr. Tushar.
Sir, good evening.
Good evening, Tushar.
Sir, any insight over restrictive cardiomyopathy?
Insight over restrictive. Sure, 110% insight over restrictive cardiomyopathy. So I'll go back and share my slides of cardiomyopathy. Give me a second.
Sure.
Meanwhile, what do you understand the word restrictive cardiomyopathy? Tushar.
Sir, there will be a restriction during the LV dilatation.
Okay.
So
And?
there is impaired feeling of LV.
Most important thing, in the presence of a normal systolic function, you find impaired filling of LV.
Yes, sir.
Can you quote any example which is consistent with restrictive cardiomyopathy in our clinical practice?
Viral myocarditis.
Viral myocarditis? No.
Constrictive pericarditis.
Ponsi? Which one?
Pericarditis.
Constrictive pericarditis.
Restrictive pericarditis? No. Most common example is atrial fibrillation.
Okay.
In atrial fibrillation, we often find people presenting with restrictive cardiomyopathies. And another example in our country, we have seen it quite often. That example is hypereosinophilic syndrome presenting as restrictive cardiomyopathy. Okay. Can you see my slides now?
Yes, sir.
All right. So Tushar, I'm showing you a patient with restrictive cardiomyopathy. This is a Rani Talwar, 75-year-old female. Her body surface area is 1.62. She was diabetic. She was hypertensive, having atrial fibrillation. And what was the indication? Coronary disease or breathlessness was the indication. And she presented for echocardiography. Now look very carefully in ECG. Echo. We have some thickness of mitral and aortic valve leaflets. LA appears to be dilated.
Yes, sir.
And when we looked at an LV size was 32 and 22. 32 is highest of LV dimensions in indexed areas. Look, we always take indexed areas and indexed volumes and measurements, because if somebody is 5'8" height, will not have the same LV size if somebody is 5.7 foot height. Somebody with 80 kg of weight cannot be matched with 120 kg of weight. So we always take index volumes and areas and measurements. So this is 32, which is higher normal. LA 32 indexed, normal is 22. So it's dilated. The most characteristic feature come, look at this 4-chamber view. What do you see in the 4-chamber view, Tushar?
RA, LV, and LA both are dilated. All the three are dilated, sorry, sir.
LV appears to be normal. I showed you LV, which was 32.
Yes, sir. It appears to be
High normal. But the most important thing is, look, the LA and RA, they are almost equal size. Normally, LA is bigger than RA.
Yes, sir.
So both of them are almost in normal size. And look at the LV function in 4-chamber view. This remains preserved. And there is small amount of pericardial effusion seen over here.
Yes,
and once we switch on colors, we'll have some amount of mitral regurgitations and some amount of tricuspid regurgitation also. Look, some amount of tricuspid regurgitation also. And most important thing is, when we go and look at their mitral flow patterns, look, this patient is intermittent in atrial fibrillation. In this now it's NSR. tall E, small a.
Yes, sir.
And EA ratio is more than 2:1. Deceleration time is 146. Anything less than 155 is considered as restrictive filling pattern.
Yes, sir.
Then what we did, we next went to E prime septum, which is 5. Then E prime lateral, which is also 5. The average came out to be 23.59. So E to E prime average is 23.59. And then we looked at LA volume is 41.44 ml per meter body surface area. Very high. And if I put all these things together, my EA ratio was more than 2. So I should be over here somewhere. E to E was more than 14, that was 23.5, and LA volume was increased. So I'm somewhere in grade 3 diastolic dysfunction. The only thing left is I have to look at my TR jet velocity. And what is the TR jet velocity? 3.2. So if I go back to my previous slide, this has got a grade 3 diastolic dysfunction. And what does this grade 3 diastolic dysfunction talks of? That's talk of LA pressures are pretty high. Suppose this patient would have been atrial fibrillation. So the parameter for evaluation of diastolic function would have changed dramatically. What we have looked? We have looked for acceleration velocity. We do not have acceleration rate. We have IVRT, we have EVP ratio and septal E to E prime ratio. My septal E to E prime ratio was EV 112 and septal E to E prime ratio is 25. So I had to be more than 11. Then I went on to do a color flow propagation velocity. What is color flow propagation velocity is? The flow across LA to LV. What is the velocity of this flow? This is normally become a linear, longer slope. So this is 46. Remember 1.2? Remember 46? E prime was 5. Then we are not considering LA in this LA volumes. And then we have what? IVRT. So I can calculate my IVRT from here. So this is closure of aortic valve. This is opening of mitral valve. If anything less than 65 millisecond, this is known as restrictive filling pattern. So if I put all these two together, of EVP ratio was definitely 1.2 divided by 23, which gets to almost more than 1.4. Septal E to prime ratio was 24. IVRT was almost 65. So even then also this patient classifies into elevated LVED. So the answer to your question is, when we have a normal LVRV in the presence of filling pressure which are elevated, dilated LARA, we consider them as restrictive cardiomyopathies. Question, Tushar?
Yes, sir. Thank you, sir.
Right question. Dr. Tiam Banikyu. Tiam? All right. Let's go to Dr. Ghansham Motisaria.
Yes, sir.
Ghansham, go ahead.
Sir, we have read a lot about hypokinesia and all regional wall motion abnormality. Can you show us all with what is difference hypokinesia, ekinesia, dyskinesia?
Okay, you want to see what is hypokinesia,
Yes.
ekinesia, dyskinesia, right?
Yes.
All right, we'll show you that. Just give me a second. Can you see my slides now?
Yes, sir.
All right. So I'll straightway start with the concept of hypokinesia, akinesia, and dyskinesia. So look at this slide first of all.
Normal, look normal.
This is a classical slide. If you concentrate on this particular segments, they are thickening constantly all segments.
Yes.
So this is in four, that was 4 chamber, this is 2 chamber, and now this is 3 chamber. If you put them in graphical pictures, normokinesis means more than 50% of thickening of endocardium. Hypo means 20 to 50%. Akinesis less than 20%. Thinning is when it remains thinned out. Aneurysm or dyskinesis is when it's bulging out. Aneurysm is when it remains bulging out. So now look at these two slides together.
Little bit hypokinetic.
Speak loudly, Ghanshyam.
Sir, little bit hypokinetic.
There is no word little bit. You have
Generalized hypokinesia.
no.
No.
First of all, you should say hypokinetic, akinetic, dyskinetic. I always say these words when we talk of hypokinesia. There is nothing like mild hypokinesia. There has to be hypokinesia. There is no hypokinesia.
Basal and mid segment, septal basal and
Now
mid
look
segment.
for septum.
Yes, this is
Look at this
hypokinetic.
basal and mid septum versus basal and mid lateral wall. This
Lateral-
basal septum appears to be almost akinetic, not thickening at all, and is hyperechoic.
Yes, sir.
From here onwards, this is hypokinetic. This is almost normokinetic if you consider this segment as normokinetic.
Okay.
Overall, this LV is poorly contracting. What kind of a LV this is? Ghanshyam,
What kind of LV?
what kind of LV? What kind of a cardiomyopathy it is?
Dilated.
Good. What takes after dilated cardiomyopathy? I taught you a very specific condition in dilated cardiomyopathy. This is non-compaction, man.
Compaction, yes.
Look at the non-compaction. How beautiful is seen non-compaction over here. And this is not only in apical segments. This is apical septum, apical lateral, mid-lateral, basal lateral also some non-compaction is seen. And if you this non-compaction is gone in mid and basal septum completely. It says somewhere over here itself. This is a very classical depiction of non-compaction of LV with associated coronary artery disease. And this is mid and basal septum, which is almost akinetic. Look, it's not thickening. It's showing just movement.
Yes, sir.
All right. Okay, let's move to next segments. Look at the right side again.
This is also non-compaction.
This appears to be almost non-compaction. But what else is seen in this slide? Look carefully in apex. Very careful.
More trabeculous.
With every contraction, the apex is moving out. It's not thickening at all. It just shows a glistening movement outside. You may or may not recollect it. I cannot be very comfortable with that. But that was dyskinesis, and this is aneurysm. Look, it's persistent bulge during diastole. This is aneurysm.
At present, I cannot differentiate.
Pardon?
At present, I am not differentiating this aneurysm. Maybe
Aneurysmal dilatation. Let me see some more are there. Now this is the zoomed up view of aneurysm. This is all dilated. persistent dilatation during diastole. This is known as aneurysm. Let me just show more. Let me see if some more are there. What kind of this motion is?
Dyskinetic.
This is apex is almost akinetic. From here onwards, apex is almost akinetic. This point.
Sir, but it's look thickening in systole.
Yeah, it looks thickening is in systole. Yeah, maybe you can say that. I can appreciate this. You can appreciating as thickness. So it could be hypokinetic.
Yes, sir.
And this is thickened sigmoid septum.
Yes.
This is normal lateral wall. I can appreciate. Good. Now tell me, what is this?
This is obstructive cardiomyopathy.
Wall motions.
Wall motion. Because septal basal segment are hypertrophic.
This is hypertrophic. From here onwards, this is all akinetic. You cannot say any thickening now. From this point onwards, the thickening started happening. Look, from this point onwards, downwards, the thickening started happening. But this segment is akinetic.
Yes, sir.
So this is akinetic. All right, let's see more. Now the akinesis has shifted to mid-anterior septum. Just this part is akinetic. Dr. Anupa, can I have a cup of tea? So what is this?
Plot.
This is a large hanging thrombus from apical segment.
Apex.
Can you see this thrombus over here?
Yes, sir.
Now tell me wall motions in this patient.
Basal and mid segment are hypokinetic.
Basal in mid of what?
Septum.
This is anterior septum. There is no septum in this. This is
Yes,
anterior.
and anterior septum. Anterior septum.
They are reasonably normal. The wall motion abnormalities lies over here in this segment. And look very carefully. The mitral valve is getting pushed to LA. Look very carefully, as if it's trying to close, and the septal AML and PML, the leaflet's body, is getting pushed into LA. This is known as, if you switch on color flow mapping, you will find significant MR in this patient.
This is flail or prolapse.
This
Flail.
is not flail, not prolapse. Neither flail nor prolapse.
Okay. In thickening of mitral valve.
Thickening of mitral valve is there, but basal posterior wall is almost akinetic. Here is the papillary muscle which is seen. So this is not posterior, this is mid inferior wall. So basal inferior wall is almost akinetic. And this is a ischemic process with which the mitral valve is being pulled into LA.
Then it would be LCX territory or RC.
LCX territory. Now see, much better LCX territory. Look at this slide again. This is from here onwards, downwards, this is almost akinetic and this is hypokinetic. And look at this bulging or bowing of PML into the LA. And when you happen to see this kind of a structure, look, all of them, they are contracting very well. Only thing is this part is lagging behind. And you see the bowing of this PML over here.
Yes, sir.
Again, circumflex.
But sir, if PML is going toward LA, then it will not be flare.
We'll come to that topic, flail, and I'll take a class for flail and this prolapse. So same patient with inferior wall territory, and same patient will have a look at very carefully now. This is beautiful 3-dimensional picture seen over here. I'll try to hold this picture for you. Look, this is what the body is. If you
Yes,
have to say it's prolapse, you join this line from this point to this point, hinge point, and measure the sentence from the line to this one. It should be more than 10 millimeters. It could be a prolapse of PML. Prolapse of body is known as prolapse, and when the leaflet gets into the LA, that is known as flail.
yes, sir.
All right,
Yes, okay. Thank you, sir.
Ghanshyam, anything more?
No, sir.
All right, Swapnil, your question. Time for your question, Swapnil. Are you there, Swapnil? Dr. Damodar alias Swapnil Arsekar. Dr. Rahul Kenkan.
Yes, sir.
Rahul, go ahead. Any questions?
Sir, could you please repeat how to calculate diastolic dysfunction in a patient with normal EF?
Okay. Let me just show this. First of all, I have to show you LV function, right?
Yes.
So look at this. Can you see the slides? No, not yet.
Yes.
Yes or no?
No, sir.
No.
No.
Sir. Okay.
No.
I appreciate I couldn't log in that fashion. Yeah. Okay. Now you can see them.
Yes, sir.
Okay. I'll go to now heart failure with preserved ejection fractions. Just a second. It's showing some abnormalities. So stop sharing and then give me a sec. It'll take a few minutes. The echo pack got logged. So meanwhile, it's getting opened up. Like, what are the parameters for normal heart failure with normal LV systolic function is? We look at E wave, we look at A wave, then we look E prime septum, E prime lateral, then ratio of E to E prime, then TR jet velocity, LA volumes.
Yes, sir.
So these are the 5 parameters we always look when we look for a diastolic function evaluations. So I'm going to show you, just give me a second. It's opening up in a few minutes. Can you see the slides now?
No, sir.
Not yet?
No.
Okay. Now you can see them.
Yes, sir.
So what is the LV function in this patient? 4 chamber.
Appears to be normal, sir.
Appears to be normal. 2 chamber
Appears to be normal, sir.
and 3 chamber. So we have to establish that LV function is normal.
Yes.
So what we'll do after doing LV function, we'll switch on our colors in 4 chamber view. Then take a mitral Doppler spectral flow that we get E and A wave. E is 85, A is 76, right? Then we'll take septum E prime ratio. So this is, we have tissue opened up a tissue Doppler, and this opened up tissue Doppler we'll measure at septal annulus, that is 7. So we are measuring at a tip of this as 7. Then we measure at the lateral annulus, tip of the lateral annulus, E prime wave, that is 8. And now we have got a, one is 7, one is 8. You can note down in your piece of paper. Rahul, E prime septum is 7, E prime lateral is 8, mitral wave is 85 and 76. Ratio is 1.12. Then we go for LA volume. LA volume is 49.5651 ml per meter body surface area, and the TR jet velocity is more than 3. Correct? Is almost 2.68 meters per second.
Yes.
So what we take a formula now, I'll just stop sharing and get back to my another presentation of please close your mic. You are opening 2 phones at the same time. Request, please close your phones. So I'm going to look at give it a breathing time, it will open the slides. You can see my presentation now.
Yes, sir.
So what were your values now, Rahul?
Sir, E by A ratio was within 0.822.
The ratio 0.82.
Between 0.8 to 2, sir.
No, 1.2 was the value, if I remember correctly.
Yes, sir. Yes, sir.
So we fall in grade 2. Then EA ratio average,
It was less than 14, sir. 12, I think.
it was
11.
12. So again, it comes out to be in grade 2. Then TR jet velocity was 2.6, 2.7, and LA volume was increased.
Yes.
So out of 4 parameters, we had one parameter, 2 parameter, and 3 were positive, and 1 was not positive.
Yes, sir.
So that patient classifies into grade 2 diastolic dysfunction with raised LA volumes.
Yes, sir.
I hope it's clear now.
Yes, sir. It's clear now.
All right. Shall we move further? Dr. Krishna Ansiram Yadav. Dr. Yadav, are you there? This is Jigna Veresh. Jigna. Jayanti.
Yes, sir. Good evening.
Good evening, Jayanti. Questions.
Sir, actually, I want to see Sam and Caudal Sam.
Oh, you're an intelligent girl. You know? All right, I'll show you Sam and Caudal Sam. Both of them I'll show you. Just give me a second. I showed you Sam a few minutes back. Were you there at that time or not?
Yes, sir, I was there, but I'm a little bit confused because sometimes I see patient with the hypertrophic cardiomyopathy, but I'm not able to distinguish, sir.
Go to M mode.
Okay.
I'll first show you Sam. And just by M mode, you will be able to see a very good Sam. Because the frame rate of M mode is so high, that's the best part of frame rate of high is that gives you a real SAM values, right? So first of all, I'll show you what is SAM, and then I'll show you a slide for a caudal SAMs.
Yes, sir.
Look, this is the first slide which did not show any SAM. Now I've done nothing. I've just set a cursor across my septum and posterior wall, touching mitral valve leaflets in Plaque's window. So what do I get? I get a systolic mitral E wave, A wave, and then close. And there is no motion of anti-mitral leaflet towards septum.
Yes.
Systolic anti-motion of mitral valve leaflet. There is no more there. Now look at my slides, subsequent slides. Same patient, another patient. This is mitral valve during systole. Look at this mitral valve during systole. Same patient, same position, cursor across mitral valve.
Yes, sir.
And if you happen to see this particular phenomena, this is known as definite SAM, systolic anti-motion of mitral valve leaflets. Are we clear with this? But at the same
Yes, sir.
time, if you happen to see this SAM, you have to see most important thing is what is the associated most important thing would be what?
Hypertrophy.
Suppose hypertrophy is not there.
MR.
Mid-systolic MR, the time
MR, yeah.
AML will go towards septum, what will happen to mitral flow? This mitral flow, this valve goes to this. So the mitral valve remained open during the time during systole.
Okay.
So it's not early systole, it's a mid-systole when the mitral valve remains open and a lot of blood gushes back into the LA through that open because this AML is being sucked into LVOT.
Yes, sir.
If you don't see MR, then you go back and see again whether there is a SAM or there is no SAM. Clear?
Yes, sir.
All right. Now, this is picture of, I showed you a few minutes back. Look, this is a still picture of, this is systole. Look at the cursor at systole.
Yeah.
And look at the mid-systolic large MR. This is a cursor just at the beginning of systole, not much MR. And now comes the caudal SAM. How does the caudal SAM? You will not find anything like in AML being sucked into. It's a phase where the cords produces obstruction. And the best part of cords produces obstruction is, give me a second again, because very classical picture is When you see two mitral leaflet crossing each other, making a cross, I'm taking a few extra minutes. Just allow me those few minutes. Got it. So this is form with new caudal cell. Just let me label it, but it will possibly create a problems. And I hope I should be able to show you this caudal cell. Good morning, friends. I'm Dr. Rakesh. Perfect. Just give me a second. Can you see my slides now?
Yes, sir.
Now look very carefully. What do you see in this picture?
Thickened mitral leaflet.
Apart from being thickened leaflet, what else do you see in this picture?
There is a
This
some
long cord.
structural
There is pretty a long cord is. Look, I'm going to freeze this AML cord. When the picture plays, the cord goes up to this point. Look at this point.
Yes, sir.
This is all cord is. Correct? And during every contraction, they are crisscrossing each other. Yeah, now look at this. They're crisscrossing each other at this point. They're crossing like this. And now this is a very beautiful picture where two leaflet, the cords are seen over here. Here's the leaflet. And now you see a cord. And this cord is being sucked into. Yeah. Can you see this PML cord being sucked? Yeah. This.
Yes, sir. Yes.
I hope this does not move. Yeah, it is. Now look at this cord getting into the LVOT. And this is systole. Valve is closed, so no MR. But when the cord goes into LVOT, what will happen? It produces a dynamic LVOT obstruction. And when this kind of a dynamic LVOT obstruction is present, it will not give you aortic stenosis. It will give you an inverted key slope shape pattern for dynamic LVOT flow. And if you cannot demonstrate, if you happen to see this, give them a Valsalva or give them a sorbitate. Reduce the afterloads. We did a post test. Even that also we cannot demonstrate good a gradient in this patient. Now look at very carefully, it's getting into the LVOT. Only the gradient, we were getting only the small amount of gradients. Now post-test we got 1.5. Look at the inverted keystroke pattern. This is not classical aortic flow pattern. Aortic flow pattern would be like quick acceleration time and longer deceleration time. And this patient came with what? He came with just chest pain. The treatment of choice is beta blockers. Got it?
Yes, sir.
All right. Anything else, Jigna?
No, sir. No, sir. Jayanti,
No,
sir.
sir?
No.
No, Jayanti was present. Jigna is absent today. Your colleague is absent today.
Yes, sir. She has gone with the nose surgery actually.
Oh. She's getting a long nose elongated or shortened?
Sir, some bone surgery.
Okay, getting nose bone removed in the nose, right?
Yes.
Okay. Dr. Ranjit?
Hello.
Yeah, Ranjit.
Sir, could you please explain me the mitral inflow pattern and septal TDI pattern in grade 1 and grade 2? And also how it changes with Valsalva?
Say it again, your question.
Mitral inflow pattern in
Okay.
grade 1 and grade 2 diastolic dysfunction.
Okay.
And their TDI. And also how it changes with Valsalva.
Okay. So you want me to go back to my old cardiac clinics. Okay. I'll do that. Let me just close down certain opened. Zoom meeting, Zoom. Okay, all are closed now. So I'll go to my documents, go to my B, heart failure. $147. Okay. Then 179. Can you see the slides now? Yes.
Yes, sir.
So this is a patient who has got a tall E wave and a small A wave, right?
Yes, sir.
And we did Valsalva with this patient. What does the Valsalva does? It reduces the flow into the LA. When we increase intrathoracic pressure, the flow into the RA and RV that's reduced, and finally the flow into the LA will reduce. The preload will reduce. And when this pattern changes from tall E to small a, from this point to this kind of pattern is small e, tall a is present. This is known as pseudo-normal kind of a pattern. Is that clear? Rahul? Dr. Ranjit, are you there?
Sorry, sir, my internet connection was slow.
Okay. So if you have this kind of a pattern where we suggest of a tall T, small a, which is classified into grade 2 or grade 3 diastolic function, do a Valsalva, it reverts to this kind of a pattern. This is known as grade 2 diastolic dysfunction. And this was done long back. Long back means before 2014. We used to classify them as grade 1, grade 2, grade 3, grade 4. So this was before 2014. I'm going to show you that slide. Just give me a second. Yeah. This was grade 1. This is grade 2. This is grade 3. So grade 1 is small e, tall a. Grade 2 is large e, small a with Valsalva, it reverts to this kind of a pattern. And grade 3 is tall e, small a, ratio more than 2, and does not show any change in reflex to Valsalva maneuvers. Here the LA pressures are almost 8 to 10. Okay, Ranjit has just joined again. Ranjit, now you are there? No, she is not there as yet. Are you there, Ranjit, now?
Yes, sir. Yes, sir. My connection was lost.
So this is grade 1, this is grade 2, tall e, small a, reverted to this kind of a pattern with Valsalva. And this is grade 3, grade 4, where we have tall e, small a, ratio more than 2, and deceleration time of less than 135 milliseconds. Deceleration time is from this point to this point.
Okay.
But this was used in before 2014. We are not using this method of grade 1 to 3.
Okay, sir.
But fortunately, I have these slides that's why I could show you. Otherwise, we were not using any more this kind of pattern. This is like 2009 when we have newer guidelines, and this is 2014 when we have further change in the guidelines to take care of all subjects in 2016, not 14, 16. But still many people, they do it. And I find this method, what you asked me, is very effective method for talking of diastolic function abnormalities. Nothing wrong about it. It's fine if you're doing this kind of a practice. Okay. Anything
Okay,
else?
sir. Sir, can you show me the TDI pattern in grade 1 and grade 2?
Tissue Doppler imaging pattern, grade 1, grade 2. The tissue Doppler pattern, I'm afraid I will not be there in my slides, because grade 1, grade 2, the tissue Doppler pattern would be more or less the same. Because we do not use tissue Doppler pattern for grade 1, grade 2. We use tissue Doppler in the sense, like I can say that whatever we see with mitral flow pattern, the same reversal of will be seen in tissue Doppler pattern. Like tissue Doppler will show small a, E prime, large A prime during grade 1, and large E and small a prime in grade 3, and grade 2, I'm sorry, I'll not be able to say, because variable kind of pattern could be present in tissue Doppler. Reverse of the same pattern could be seen in tissue Doppler. You can understand that much. But we are not using that pattern for calculation of diastolic function, neither before 2009 or 16. Okay.
Okay. Okay, sir.
So if you are using, use only mitral flow pattern. Don't use tissue Doppler for calculating grade 1 to 3 kind of a patterns. If
Okay,
you're
sir.
looking at those things, once you're looking at tissue Doppler, then you should talk of 2016 onwards parameters.
Okay, sir.
Right.
Thank you.
Right. Thank you. Dr. Dalip Bhatkar Pandit.
Yes, sir. Good evening, sir.
Good evening, Dalip.
Sir, can you show me please the right ventricular function by tissue Doppler imaging? How to assess right ventricular function?
All right, good. So let me close it down. Done. Right ventricular function by tissue Doppler. Give me a second. I'm opening my slides. PAH, all pulmonary.
TDI वापरायचंच नाही हे पाचवी बघायची सवय लावायला पॅटर्न आमच्या नोट्स मध्ये आहे सर.
Okay, slide 137.
आमच्या तात्याचं अजून माणसालाच वापर.
Ranjit, please silent your mic. Can you see my slide here?
Sir, I can see.
Okay. Delete. This is what is a tissue Doppler across RV free wall. So this is TDI across RV free wall. We keep a sample volume at the TDI point of RV free wall at over here. And then what we get is tissue Doppler flow across RV free wall. This is septal E wave. This is isovolumic relaxation time. This is E prime lateral RV free wall. This is A prime RV free wall. And this is isovolumic contraction time. So by this, we can say how much my LV is contracting. Look, if I look at this, my cursor, this is almost 14
yes,
centimeter. Anything more than 9.5 is considered as normal.
Normal. Yes, sir.
Then what we take a ratio of E wave of tricuspid valve and E prime. So E prime would be this. This is E prime would be here. So ratio of tricuspid and E prime will give me a value for diastolic function of RV.
Okay, sir. Sir, and if in particular this case, if we don't have the function of tissue Doppler imaging, so can we use simple pulse wave Doppler on the free wall to assess the
no,
function?
because when we switch over tissue Doppler, what does it do? It gets rid of a high flow velocity of tricuspid flow, and
Yes.
it assesses only the myocardial contraction of RV free wall.
Okay. Okay, sir.
Right?
Yes, sir.
All right. Let me move on to next, Dr. Dinesh Tiwari. Dinesh, are you there?
Yes, sir.
Yeah, Dinesh,
Sir.
go ahead.
So I just want to ask about the right ventricular systolic dysfunction measurements.
Systolic dysfunction. So that two
Yes, sir.
systolic dysfunction are present. One is RV free wall TDI, which I showed you a few minutes back.
Yeah.
If it's less than 9.5 centimeter, this is systolic dysfunction. Second is TAPSE. You put an, instead of this, you put an M mode. If M mode shows less than 17.5 millimeter of dispersion, that is systolic dysfunction.
Oh,
Are you
okay.
clear with TAPSE and that? RV free wall I showed you, TAPSE, are you clear or not?
Sir, I'm not clear about TAPSE.
Okay, I'll show you TAPSE then. What's the problem?
Yes.
This TAPSE is simple thing, man. We'll do that. So we go back to again pulmonic. MNP. Okay. Give me a second. The slides are opening up. The computer is a little slow. Can you see the slides now?
Yes, sir.
So what we did, we went to 4-chamber view and we went to RV focused view. So we put a cursor across this tricuspid valve, right? Tricuspid annulus, not valve, annulus. What we see a systolic entry motion of tricuspid valve. So with LV contraction, this will go up, right?
Okay.
When this will go up, we measure up this right from this point to this point. That is known as TAPSE or tricuspid annular plane systolic excursion more than 17.5 millimeters. Next is RV free wall TDI. I showed you RV free wall TDI.
Yes, sir.
So these two functions are important to look for RV functions.
Okay, sir. Thank you, sir.
Not at your syllabus level. This is RV 2-dimension strain. Anything more than 20 is considered as normal. Less than 20 is considered as abnormal. And same thing you can do in your okay. So suppose I've got this patient and if do my caliper controls. No, not in this. Okay. See. No, just I was trying to say is just put a M mode like this. It'll give you a task.
Oh.
Right?
Okay, got it, sir.
Anything else, Dinesh?
No, sir. Thanks.
All right, thank you. Dr. Bhimrao Pawar. Bhimrao Pawar, are you there? Rakshit Bhardwaj.
Hello.
Dr. Rakshit Bhardwaj.
Hello.
Hello. Oh, Dr. Pawar, I could get you now. Dr. Pawar, any question? Dr. Rakshit Bhardwaj. Ankan Patel.
Yes, sir. So good evening, sir.
Good evening, Uncle. You were traveling?
No, sir. I'm in duty, sir, in ICU, sir. That's why.
Okay, okay, great.
Sir, actually, sir, I just wanted to know about the speckle pattern, sir. I couldn't understand it, sir. Taught, sir, but I couldn't understand it, sir.
What's the pattern? Speckle patterns means what?
Sir, in the systolic function of left ventricle, sir, the speckle pattern, sir.
अरे बाप रे, तुम तो बहुत सारी बातें पढ़ना चाहते हो. Okay, पढ़ाते.
No, sir, sir actually taught, sir.
So we go to let me just look whether I'm able to get this speckle pattern over here or not. There was so just hold on, I'll have to go to my TDI topic. Give me a sec. This is what I recorded recently, so I'll just show you that. Echo in artificial intelligence. This is self-explanatory. Look. Uncle. So what we do, we get a 3-chamber view. Then we trace these margins. This machine does it automatically. Analyze the machine. And now it has given you a 2-dimensional strain across all the segments. Ankan, are you there? You were lost. Ankan?
Yes, sir.
Now you can see it, or I'll go back and show you again.
Sure, sir, please, sir.
So it's tracing all the margins of a 2-dimensional strain. That was initially 3-chamber. This is 2-chamber. And it's giving all the strain value of all the segments, right? And this is GLS. At the same time, it's giving ejection fraction also.
Sir.
And then we do a 2-chamber view. This is speckle imaging, does a 2-chamber view, trying to adjust the margins. So this is a global longitudinal strain of 23% of 2-chamber. And this is a global ejection fraction of 4 and 2 chambers together, 61%. These are all dimensions. And then we'll go to quad values. So now this is a polar map. So all 3 views are seen together, and then the polar map to talk of global longitudinal strain. At the same time, we are getting ejection fraction also 61%. So we are back to original one. We have started with 3 channel. Like I'm sure, like whosoever had taught you, this is like thing we did not touch to begin with, because this we consider as level 2. Once you understand the basic systolic function, this becomes easy.
Sure,
Anyway,
sir.
right?
Sure.
Anything else I can show you, Uncle?
No, sir. Thank you, sir.
Right, Uncle. Take care.
Sir.
So next I'll go towards Dr. Nitin Gupta. Nitin, are you there? Hiru or Amin? Hiru, are you there? Dr. Sirisha? Ganesh, Sirisha, go ahead.
Sir, is there any protocol or stepwise way of doing a screening echocardiogram, sir? I don't know whether I can ask you this now, but
you can do a screening. There's nothing like screening echogram, Sirisha. First of all, we should give up this word of screening.
Sir.
Echocardiogram is echocardiogram. And I always say these words. If you are doing echocardiography, there's nothing like screening.
Yes, sir.
You do a stepwise complete echocardiogram.
Sir.
Okay. So
sir.
you go to website, you'll find my video of step-by-step echo evaluation.
Okay, sir.
It's on there on the website. You'll find
Yes,
the videos where how to do echo and interpret it. It will there. And I'll just jot it down. Once I'll find it, I'll send it across to you also in this group also.
Okay, sir. Thank you, sir.
Right, Sirisha. Dr. Ganesh Tukaram Thomare. Ganesh, are you there? Dr. Sayali Nandkumar Bhangre. Sumant Kumar. Ishwar Agarwal. Anupa George. Dr. Anupa, are you there?
Good evening, sir.
Good evening, Anupa.
Sir, I want to know about what is this deceleration time and acceleration time?
Okay. Good question, Anupa. Great. Just give me a second for a second. I'll open up my I'll take up any Doppler flow. All right, this is the Doppler flow across mitral valve. So if I measure my timing across this Doppler flow is, I'll go to time.
Not seen anything.
Not seen? I'm
Yes.
sorry. I'll go back again. Don't worry about it. Just give me a second. Can you see the screen now?
Yes, sir.
Yes, sir.
Okay. So I'll go to, this is mitral flow pattern. In this mitral flow pattern, this is deceleration time. So I'm going to measure my deceleration time. I'll go to mitral valve. Oh, just again, it's a problem. Give me a second, error has happened. So I'll have to close it down first. Okay, it's ready. Can you see my slides now clearly?
Yes, sir.
Okay. So I was talking of anything I can, doctor, I can go towards any subject I can. Yes. So I'll pick up my mitral flow first. All right. Now I'll go towards measurements. Go to mitral valve and look at this screen. Now you can see this is EA ratio, right? So this is E wave, and then I'm coming to bottom along with the slope. This is known as deceleration time. Look at the left side of a screen, 230 milliseconds. Can you see the deceleration time?
Yes, sir.
So this is mitral valve deceleration time. This is for mitral valve. Okay. Now let me go towards another part, that is aortic flow. So in aortic flow, we'll have both acceleration and deceleration times. All right. This is not aortic flow. This is pulmonic flow. If I have to measure this pulmonic flow, so what I'm going to do is I'll go to measure, then I'll go to times, generic, then time. So the acceleration time in this patient would be from this point to peak of this point. This is not a very clear graph, but this is the peak of this point would be acceleration time, and from here to here is deceleration time. I'll measure this. If suppose this is a peak of this wave, so this is acceleration time, and from this point to this point is a deceleration time. The importance of this acceleration deceleration time is very important, because in aortic stenosis, as I said, this will have a shorter acceleration time and long deceleration time, as shown over here. As soon as there is hypertrophic obstructive cardiomyopathy, this will be a long acceleration time and shorter deceleration time.
Sir, acceleration time means
onset to peak
of flow.
Of onset to peak of flow. Correct.
Okay.
Look, this is very clear. Now, if this is aortic only. If I have to measure this timing, I'll go to measure, go to timer. This is onset to peak. Now look at my cursor, will stop at the peak.
Sir, is it the slope or?
Slope would be different. Slope would be when we if I'll draw my line from here to here, that will be a slope.
Okay, that is different from this time.
Right, this is time. Now look, the parallel I've measured how much time it took for acceleration.
Okay, okay.
And from the acceleration mid of this acceleration time to this point is deceleration time. Okay. What you're looking for slope is, in which context are you looking for slope? Anupa?
Which context means?
In which context?
In diseased?
No, in which mitral stenosis, aortic stenosis, in what condition are you looking for a slope?
Regurgitation.
Pardon?
Regurgitation.
Regurgitation. Okay.
I didn't understand, sir.
Ghanshyam, regurgitation, that's a different thing, If I don't know, like what is there in your mind to look for a slope?
We are looking slope in ES slope when we are looking for mitral stenosis.
That is different. That is a very simple thing, like if she's looking for EF slope or mitosynosis, that is what exactly she knows. She is not in this. Let me just look at it. I'll just create that slope. Yeah, it is there. Okay. If this is what you're looking for, this is known as EF slope. Can you see the left side of my arrow? This is EF slope.
Yes, sir.
Anyway, think over it again and I'll get back to you. That's not an issue. Okay, Anupa?
Sir, no, I want to know this. We are telling the short acceleration time and that any relation with the slope of that wave.
No, there's no relationship with the slope of the wave.
Okay.
Okay. Let me just tell you what exactly we mean by. What if I'm correct? What you're saying is this is what the slope is. If this slope is longer, that is means a longer acceleration time. If this slope is slower, that is a shorter acceleration time. Is that right?
Yes, sir. Yes, sir.
So instead of saying slope, we say a longer acceleration time is when we measure like this. Will be measure this point time over here. So longer slope means slower, and shorter slope means smaller acceleration, deceleration or acceleration time.
Oh, okay.
This is a slope which is quick. So this is a shorter acceleration time. This slope is long. So the deceleration, this slope is slower deceleration time.
Okay. Okay. Now I understood, sir. Okay.
I think this is now clear. Like that, even I took a time to understand. I think this is fine. Okay.
Okay. Okay, sir. Thank you, sir.
Thank you. Amit Potulwar. Amit, are you there? Umesh Raju.
Sir, what is color flow propagation velocity?
Color flow propagation velocity. Okay. Great. I love it when somebody asks me a good questions. So if I keep my M mode into this sector, can you see this, my M mode into this sector? The
Yes, sir.
flow velocity, which is acceleration time, is known as color flow propagation velocity. This is not like I've acquired it in this, but this is not the right way. What we do is we just keep a M mode over here. This I've kept a cursor. So we'll get a slope over here, right? And how the slope looks like, just a second. So now your procedure, you know how to do it. So I'll stop it over here. Go to my diastolic function because that's the better depiction of. This time I'm not going to close my diastolic functions. I hope all of you can see my slides now. Getting rolled up.
Yes, sir.
Okay, just a minute. It's not seen in this. Before that is one more slide which I could pick it up right now. Somebody was asking me that. Somebody was asking, I'll come down to slope, flow propagation velocity. Give me a second. So somebody was asking me how to evaluate Mitosynosis, the diastolic flow patterns. What we do in Mitosynosis is we look at a mitral flow pattern, then we look at tissue Doppler pattern at the mitral annulus. And what we look at the end of a T wave to opening of the mitral valve. Can you see this end of T wave to opening of the mitral valve? That will be first interval, then end of a T wave to opening of E prime ratio. And this point is taken into validity. And how do we take it? IVRT divided by time of E minus E prime. I'll repeat it again. This is a QRS complex over here. So this is PQRST and here is end of a T wave. At the end of a T wave, what we see a mitral flow pattern. So interval between end of a T wave to opening of mitral flow pattern, end of T wave to opening of E prime. So this timer and this timer are two different timers. And when we take IVRT from this, like we have taken IVRT from here, then IVRT divided by this time, if it's less than 4.2, we consider this as elevated LVDP in mitral stenosis. Or we take IVRT itself per se to talk about raised LVDP or not. So this is I could come across that slide. That's why I've holded it for the time. So let me just now go back to my flow propagation velocity. There was flow propagation velocity. I don't know where it is, but let me just find it out. Oh, yeah, it's pulmonary venous. Yeah, it's here. We have been roaming around at multiple places to see a flow propagation velocity. Can you see the slides now?
Yes, sir.
Dr. Umesh Rajur,
Yes, sir.
you asked this question, right?
Yes, sir. Yes.
So what we did, this is an Mayo's Clinic places. This is LV, this is LA. We keep an M mode sector volume across this, and we switch on colors. And this is how the E wave is. This is A wave is, and this is systole. Correct? Again, E wave. This is diastasis. This is E wave, A wave. So what we do, we measure the linear slope across this line of first aliasing, go up to 4 centimeter up. So if we go up along with this line of like yellow, red, and blue, look, there are 3 lines are there. If we go across this first aliasing line of red and yellow and go up 4 centimeters across the slope is, then this is known as color flow propagation velocity. Normal is more than 55. Restrictive filling pattern is less than 35 centimeters per second.
Okay.
This is the method still used in number of conditions like atrial fibrillation. EVP ratio more than 1.4 is restrictive filling patterns. Okay.
Yes, sir.
Anything else, Ramesh?
No, sir.
All right. Dr. Safaila Sardesai. Dr. Safaila Sardesai, are you there? Dr. Mitul Jain, Namdev Limbaji Chaure, Suman Chatterjee, Anchala Singh, Rahul Gore.
Sir, can you tell pulmonary venous flow pattern?
Pulmonic venous flow pattern. Okay. Can you see the slides now again?
Yes, sir.
So I have kept these 2 things together. This is the ECG gating. Look at a QRS complex from here to here. So this is systolic forward flow. This is diastolic forward flow. And this is atrial reversal kick.
Okay.
Kick has got a duration as well as time. This is a duration and the amplitude, not time, amplitude. Normal S wave is bigger than D wave. This is another example where we have a large E wave, S wave and a small D wave. And this is normally, it has to be like we call them S wave 60, 40 to 60, D wave 35. Ratio is 1.3 to 1.5. Systolic forward friction is when systole is divided by S and D into 100, that is systolic forward frictions. Then AR duration is less than 137 milliseconds. And AR velocity is 35 centimeters per second. A wave duration is 125 milliseconds. This is mitral valve. So S and D, that's how we take it. This is useful even today also in circumstances where we have to talk of patients having grade 4 diastolic dysfunction. What is grade 4 diastolic dysfunction is when E wave duration is AR duration is more than A wave duration of mitral valve by more than 35 milliseconds. That is known as grade 4 diastolic dysfunction. So at your level, just remember that S and D waves, and that'll be more than enough. If you have systolic MR, S wave will get truncated. This S wave will become smaller, D wave will become taller. This is pulmonic venous AR. AR is, this is duration of AR, and this is the velocity of AR. This is A wave duration of mitral flow pattern. In grade 4, this duration becomes bigger than this duration. Normally, A wave duration is more than AR durations. And grade 4 is non-reversible. It means the LA pressures have gone so high that they are not being reversible by medical therapy. Okay?
Okay, sir.
Dr. Anchala Singh? She is not there. Rahul Gore? You have asked the question, right?
Yes.
Rahul, did you ask this question, right? Correct?
Yes, sir. Yes, sir. I asked. Just now.
Dr. Shashank Prabhu Desai? Shashank, are you there? Jai Singh?
Good evening, sir.
Good evening, Jai Singh.
Sir, my question is regarding RWMA. Sir, at short axis, to describe the RWMA, we are using 16 segment model.
Correct.
At the short axis, where at the papillary muscle level, where the papillary muscle are attached, we are saying that these are showing inferior wall and lateral wall. I am little bit confused that why we are using word wall, because and rather than we are using to describe the word segment. But will I have to write that if inferior wall or lateral wall is hypokinetic or inferior wall segment is hypokinetic?
Okay.
If
Just give me a second. Let me just open up that presentation. Okay. Can you see my slides now over here?
yes, sir.
All right. So this is a slide at the level of papillary muscles.
Yes, sir.
There are two papillary muscles, one over here, second over here.
Yes, sir.
Now this is septum.
Yes, sir.
Opposite to septum is which wall?
Anterior wall.
Posterior wall.
Opposite. अच्छा यहाँ किस हाँ ठीक है.
Go to septum is
Yes, sir.
posterior wall. Correct?
Posterior. Yes, sir.
No, sorry. Opposite to septum.
Lateral wall.
Lateral
wall.
So this
Lateral
is lateral wall. So lateral wall has got a papillary muscles.
Yes,
This
sir.
is anterior septum. Opposite to anterior septum is which wall?
Posterior wall.
So here is posterior wall just opposite to posterior wall.
Yes, sir.
Here is anterior wall.
Opposite is inferior wall.
This is an inferior wall. So inferior wall has got a papillary muscle and lateral wall has got a papillary muscle.
Yes, sir.
So where is the confusion?
Sir, at this particular level, these are segment. Then why we are saying that this is inferior wall. Wall, it is a major area. No?
Your perfection is perfect. We should say that as mid septum or mid lateral wall or segment, mid lateral segment, not
Yes.
wall. We
Yes,
should say
yes.
mid lateral segment or mid lateral wall, not lateral wall.
Right, sir.
Correct. You are absolutely correct. Any other question, Jesse?
Sir, at plaques level, if papillary muscle is showing is attached in plaques view, that time that will be show inferior wall or posterior wall.
Whenever
And
you see a plaques, must look there are two images based on a question. One does not show plaques, papillary muscle, other shows papillary muscles. This is posterior wall, this is inferior wall. If you happen to see a papillary muscle, that is inferior wall, not posterior wall.
Then what should do I have to do to watch posterior wall in plaques view, sir? If papillary muscle is
Manipulate your transducer in such a fashion that this inferior wall become posterior wall. Manipulate means what? I'll tell you what exactly means manipulation.
Right, sir. Yes, sir.
In this, where is posterior wall? Septum, and this is
in between
lateral wall. This is anterior septum and posterior wall here.
Yes, sir.
So you have to angulate your transducer little towards laterally so that you get rid of
laterally.
plaques window. You have to angulate your transducer slightly towards left shoulder.
Okay, sir. Okay, I will try, sir.
Right.
Or sir, can you show some picture of right ventricular infarction or right ventricular regional motion abnormality?
Yeah, sure, I can. Why not? I can show you everything, man. Don't worry about it. If somebody steals my this laptop, you know, this is everything is there in last 20 years, 30 years. Give me a second. I'll show you.
Yes, sir.
Okay. Now look at this picture over here. Look, this apex is contracting. Jesse?
Yes, sir.
And this is stationary. Apical sparing is present, but this is almost stationary. And when you do a tissue Doppler in this subset of population, what will happen? With inspiration, the TDI velocity will increase. That is going up to almost 10, 9.5 or 10. But during end expiration, the velocity is only 7 or 8.
Okay.
I hope and we did a 2-dimension strain. In this 2-dimension strain, its value is only 8.1, which is normal.
Okay, sir.
Right?
Right, sir. Sir, my another question is regarding HOCM. Sir, if patient comes after myomectomy, then SAM will be there or not?
Good question. If patient has come after myomectomy, the SAM depends on how much myomectomy has been done. Look, myomectomy is a very difficult procedure, to tell you very honestly. Nobody does a complete myomectomy because we are likely to create VSDs. When muscle is contracting, it looks thickened. When the muscle is like non-contracting, it looks like it's not hypertrophic. So in principle, if you say, I'll say that after myomectomy, you should not see any thickening of the muscle. And there should not be any gradient.
Okay, sir. Thank you, sir.
Right?
Right,
Dr.
sir. Thank
Shrikant Rajvilas Gote.
Hello, sir. Good evening, sir.
Good evening, Shrikant.
You already answered my first question, diastolic dysfunction in AF. My second question is, sir, how to differentiate septal kinesia from the septal dyssynchrony secondary to bundle branch blocks?
Okay. So I'll go to my wall motions abnormalities again. Now look at this slide. This is categorically left bundle branch block. Can you see this? This is septum.
Yes, sir.
But this is thickening. You have to be very cautious. This is thickening. First point. Correct. And if you do an M mode in plaques window of the same patients, what will happen? In M mode of the same patient would be like I have done this in anterior septum, same anterior septum I have done it. In this, it'll show this kind of a beaking kind of a pattern in M mode with thickening.
Okay.
But if it's hypokinetic, this will not show a beaking pattern. This will show a thinned out septum. Second important thing is when you have an anterior wall changes, what will happen to anterior wall? In LBB, anterior wall function will be preserved. In CAD, anterior wall function would be affected.
Right, sir.
Correct? So that's how
Right,
we
sir.
differentiate between LBB presenting with no eyes or of no significance versus coronary artery disease.
Got it.
Got it? Anything else?
Yes, sir. No, sir.
Yeah, go ahead. That's all?
No, sir. Yes, sir. That's all.
Pardon?
That's all, sir.
That's all. Okay, thank you, dear. So next is Dr. Vinay Sharma. Dr. Anudeep Reddy.
Hello, sir. I don't have any questions.
Yeah, Anu. Any question?
No, sir.
Dr. Karan.
Just,
Dr. Samrat Madanik.
Yeah, good evening, sir. Sir, you have already answered my first question regarding the systolic fraction in pulmonary venous Doppler. So my second question is, sir, how do we exactly calculate the LA mean pressure, sir?
How do we exactly calculate LA mean pressure? What are LA mean pressures? Diastolic function evaluation is LA mean pressures.
Yes, sir.
We don't calculate it directly. If you want to collect directly, that then invasive process.
Right, sir.
Non-invasive processes like normal diastolic function means my LA pressures are 8 to 10 millimeters of mercury.
Right, sir.
If it's grade 1, it's 10 to 12.
Right, sir.
If it's grade 2, it becomes almost 15.
Yes, sir.
Grade 3 is more than 15 up to 20.
Okay.
That's how we consider this LA mean pressures.
Okay. So can we strongly correlate it with the pulmonary artery diastolic pressure, sir? If we have the values of pulmonary artery diastolic pressures,
Yes.
can we?
We can correlate in the absence of any lung condition.
Yes, sir.
If the lung condition would be there, then it will be irrelevant.
Yes, sir. Thank you, sir.
Right. Dr. Meghna Das, Tamogna Das. Tamogna.
Good evening, sir.
Yeah,
Sir, can you show how to calculate the pulmonary artery pressure in the presence of pulmonary stenosis?
Very simple. Can you get TRZ gradient in pulmonary hypertension?
Yes, sir.
Suppose the TRZ gradient is 4 meters per second.
Yes, sir.
So what would be the gradient?
So the pressure will be 4 into 4 square.
4 into 4 into 4?
Yeah.
64.
Yes, sir.
Then add RA pressure to it.
Yes, sir.
Suppose RA pressure is 10, then is 74.
Yes, sir.
Correct?
Yes, sir.
So you have got one value which is 74. Now take your pulse wave Doppler spectrum pattern across pulmonic valve.
Okay.
And switch over continuous wave Doppler spectrum pattern across pulmonic valve. So get a peak velocity. Suppose the peak pulmonic velocity is 2.5. So what would be the gradient across peak pulmonic stenosis?
2.5 into 4 square.
25.
2.5 into 5,
25.
2.5 into 2.5 into 4.
Yeah.
That will be 25.
25. Yeah. Yes.
74 minus 25
25
would be exact pulmonary artery pressure, peak pulmonary artery pressure. Let's make it 74 as 75. 75 minus 25, that will be 50 your peak pulmonary artery pressure. Then multiply 50 by 0.6, add 2.1 will give you mean pulmonary artery pressures.
Okay. Okay, sir.
Clear?
Sir.
Anything else?
Sir, regarding the assessment of right ventricular function, if we are not able to visualize the IVC, you had said something about visualization of the junction of the hepatic vein with the IVC and seeing the flow pattern there. So can you please elaborate on that?
Your question is little vague. Your question is, say it again, first of all.
Sir, in case of assessment of the right atrial pressure, we can do it by visualization of the IVC. In case it is not there, so can we use the junction of the hepatic vein into the IVC?
No.
And
no. In case you can't see IVC, the next answer would be to look for E to E prime ratio of a tricuspid annulus.
Okay.
E wave of tricuspid flow and E prime of tricuspid annulus, anything more than 6 is normal, less than 6 is abnormal. More than 6 will tell you RA pressure of more than 6 millimeters of mercury, and less than 6 will tell you RA pressure of more than 6 millimeters of mercury. Less than 6, more than 6.
Okay. Okay, sir.
We don't use that IVC RA junctions. Then we look at E to E prime ratio, or we look at pulmonary extraction time, but I don't promote pulmonary extraction time because that is very variable. So RA would be like, answer would be look at E to E prime ratio.
Okay, sir.
Of tricuspid valve.
Okay, sir.
Right? Durgesh Makwana.
Yes, sir. I had a doubt when we check the mitral inflow pattern in a pseudo normal pattern we get, we differentiate it by Valsalva manure and tissue doctor. Imaging, looking at the normal velocity and QnA time. Can you explain that again, sir?
Okay. What is pseudo-normal pattern? First of all, I must tell you what is pseudo-normal.
That would be, sir, after the actually as the ventricles get stiff, the LA pressure rises, and the E wave will have a means the initially the rapid filling phase will have the same height as it was in the normal pattern.
Correct.
And EA ratio remains same.
Correct. I got it. So what do we do in that is, let me just find out a slide. I hope you are seeing my slide already. So this appears to be reasonably normal. Suppose this pattern is there. So, but it is a tall E, small a, and the ratio is between 1 to 2. In truly grade 3 diastolic dysfunction, this will be tall E, small a with a ratio of E ratio more than 2. When the ratio is between 1 to 2, what do you do? Whether you do not understand this is normal or abnormal. So do you Valsalva in this patients, and this ratio changes to this pattern changes to this pattern. This is known as pseudo-normal pattern. It means the LA pressures are not normal. LA pressures are borderline elevated, like 12, 15, or 13 or 14. Clear?
Okay. So when we give pseudo Valsalva manure, the ratio would be maintained in a normal LA pressure patient in a normal pattern. But when it would be pseudo normal, we'll have a reversal of that ratio.
Correct. And significance comes where, you know, somebody who's hypertensive, diabetic, walk into your clinic with a breathlessness, and you look at a flow pattern which is normal diastolic pattern, then you should get alarmed. Look whether his patterns are elevated or not. Then you should do a pseudo-normal pattern. As a Valsalva manual. Second thing is, suppose you have a normal reduced LV systolic function, and you find this pattern to be this one only. How can you accept a reduced person who has got a reduced LV systolic function with a normal flow pattern? It can happen. But in those cases, you should do a Valsalva to unearth or delineate between pseudo-normal versus elevated also. If it's a grade 3 diastolic dysfunction, it will not change at all. And if this somebody asks me this question is, you look at a deceleration time. If this deceleration time is less than 135 milliseconds, EA ratio is more than 2:1, definitely this patient has got a elevated LA pressure, which is approximately 15 or more. And if you do a Valsalva in this patient reverts to this, it means LA pressure are still at a lower side, 10 or 12. Okay?
Thank you. Yes, sir. Thank you.
Dr. Kevin Bora?
No question, sir.
No question, Kevin? Tired?
No, sir. Not tired. My questions were answered in the beginning itself.
Okay. Ravi Bhushan? Chandan Mahapatra?
Sir, already my all the question are answered, but still I want to know the calculating the sir in case of pulmonary hypertension by TRJ. Sir, I just want to again just
Speak a little louder and clearer if I can understand your question here.
Sir, I want to know the calculating the pulmonary pressure in case of PH by TRJ. Just I want to know again.
Okay, you want to see how do we calculate it, right?
By just simplifying the process, by doing the 2D process, how you know in a simplified method there is severe pH or moderate pH.
I'm going to do that. Just give me a second. You are able to see my slides now?
Yes, sir. Yes.
Okay. Now this patient has got a severely elevated pulmonary artery pressures. So his gradient, if you happen to look at the peak velocity, is 5 meters per second, which correspond to almost 100 millimeters of mercury of TR jet gradients.
Yes, yes, yes.
In this, like if you measure the peak, it'll give you a gradients. Now this is a TR jet, which is peak velocity. Now you add RA pressure to it. You look at an IVC. Suppose IVC is normal contracting. RA pressures are 5. So we call them as 105 millimeters of mercury of peak pulmonary artery pressure. From peak, we have to calculate mean pulmonary artery pressure. So for calculation purposes, let's think which are 100. 100 into 0.6, add 2.1. 100 into 0.6 will be 60. 2.1 is 62.1. So any pressure which is less than 25 millimeters of mercury is considered as normal. 25 to 35 is mild. 35 to 45 is moderate. More than 45 is severe pulmonary artery hypertension.
Yes.
Is that okay?
Yes, sir. Okay, sir. Thank you, sir.
All right. Next is Dr. Yogesh Namdev Patil. Yogesh, are you there?
Yes, sir, I'm there, but most of my questions have been answered already.
Okay, great. Dr. Majrul Islam.
Yes, sir. I have a question, sir. In coronary artery, if sir LCX is 90% is stenosis, so can you show some images, echo images of LCX and LAD has been steno 90
Okay,
or 95%?
I'll show you the images for LCX and LAD. Just give me a second.
Yes.
All right. Can you see my slides now?
Yes, sir.
Okay. What are the territory for circumflex, dear? Majrul?
Yes, sir.
Territory of circumflex.
So posterior wall of LV, sir.
Infra-posterior lateral wall, basal infra-posterior lateral wall, right?
Yes,
so
sir.
look, this is lateral wall, mid-lateral,
Yes, sir.
basal lateral, hypokinetic, and look at the bulging of this PML, because this cord has become looser now because of ischemia. If this is associated with in basal inferior wall, again hypokinetic.
Yes.
Along with posterior wall, this is hypokinetic. And when we have this, Both lateral wall and inferior wall, they have got a papillary muscle, and those patients will have significant ischemia leading to mitral regurgitation. Now they look, they have got a significant ischemia. Can you see that mitral regurgitation?
Yes, sir. Yes, sir. Mitral regurgitation.
Now, sometimes we look at only mitral regurgitation and try to find why this mitral regurgitation is there. Because the valve is normal, wall motion abnormalities are not there. That is occult ischemia. So we ask the patient to walk for a certain distance, and is MR increases and wall motion abnormality across basal inferior posterior lateral wall appears. Now let's see this pattern again. This is again basal inferior, basal posterior wall. Same patients which I showed you a few minutes back.
Yes, sir.
Severe mitral regurgitation.
Yes.
Now this is left main lesion. In left main lesion, what happens? You will find territory of circumflex alveolar LAD. Only mid and basal septum would be preserved.
Yes, sir.
Look, this is our this is almost akinetic. This is hypokinetic, and this is normokinetic. All three things. Look at the thickening of this mid and basal inferior wall, mid and basal anterior wall, and look at this anterior septum apex. This is akinetic. This is hypokinetic. This is normokinetic.
Yes, sir.
Look at the normal contraction of posterior wall, and this is almost hypokinetic. So if you have a left main, you have a circumflex as well as LAD changes.
Yes, sir.
Fine, dear?
Yes, sir.
Dr. Nida Khan, next.
Yes, sir.
Yeah,
So what is burned out phase, sir?
What is bundle of?
Phase.
I'm sorry, I couldn't get it again. Say it again.
The burned out phase, sir. Usually, many times they say these things, use this term, burned out phase.
Burned out phase.
Yes.
Oh, this is a slang, you know. What is burned out phase means in wall motion abnormality you're talking about, right?
So in sometimes in hypertrophic cardiomyopathy also they say those things, and in ischemic heart disease also.
Yeah, ischemic heart. I now got it. What exactly they were looking for. You can see my slides again?
Yes, sir.
Okay. In the slide did not like this word, you know. Neither?
Yes, sir.
Slide also did not like this word. This is they are burning me out completely. Burned out phase means neither the answer is for burned out phases when the segments become akinetic, their thickness is less than 6 millimeter and they're hyperechoic. And I was trying to look, just show me, give me a second. I'm trying to look at those kind of things. And if I'm able to show you, that's burned out phase. I hope this slide plays. Yeah, it is got it. So look at this slide over here. Till this point, there's some contraction which is present over here, right? Both in septum as well as lateral part.
Lateral.
But if you look at the apical part of this image, this is almost thinned out and it has become aneurysmal. And this is what is burnt out phase, where we cannot do anything with the subset of populations. Got my word?
Yes, sir. Yes, sir.
Anything which has become akinetic, hyperechoic,
which has seen no contraction, the endocardial thickness or myocardial thickness has gone less than 5 millimeter or 6 millimeter, that is burnt out phase completely. It could be applicable in other subjects also, like severe aortic stenosis and LV function has gone down to 0. 0 means 25-30%. That is virtually a burnt out aortic stenosis. The diastolic function going to grade 4, burnt out diastolic function, where any efforts doing something with the patient would not be useful. Okay.
Yes, sir. And anything about LA strain, sir?
Neither you have gone ahead to level 3.
So because usually nowadays they talk about LA strain a lot, sir. So anything about it?
Okay, give me a time. Let me just see that presentation for listing.
Sir, sorry to interrupt you, Dr. Samrat here.
Yes,
Sir,
sir.
in the last aneurysmal slide, what you showed, is that the false tendon that we are able to visualize?
Yeah, that like what exactly happened. Once we look at this false tendon, and many people combine it as thrombus.
Yes, sir. Yes, sir.
And it was very difficult to explain to everybody. Look, this is not thrombus, this is false tendon.
Yes, sir.
We went ahead to do an transesophageal echocardiography to show them this is false tendon. This is not.
Right, sir. Right, sir. So, sir, how do we? Is T the answer to?
If people do not understand, T is the answer.
Yes, sir. Yes, sir. Thank you, sir. Thank you, sir.
If they understand, it's fine. Fair enough.
Yes, sir. Thank you, sir.
Neither what exactly the LS strain today is. We are looking at this LS strain to classify them as grade 1, 2, 3, and 4. And this is more appropriate method than looking at LA functions, correct?
Yes.
And how do we look at them? And I'll just show you that slides so that this is what is going to happen in the time to come. Like this is one in thing which has started happening where we can predict LS strain at a much earlier phase, correct? So I'm just going to show you the certain slides for that, and then possibly you'll have some idea about it. Can you see my slides now over here?
Yes, sir.
So what we do, as we trace the LV cavity, we trace the same LA cavity also. And it gives you a LA strain in this subset of population, and that it lets you divide into grade 1, grade 2, grade 3, grade 4. So here is the grade 1, 2, 3, 4 of a LA strain, or group 1, 2, 3, 4 of LA strains. And based on this grade 1 to group 1, 2, 3, 4 of LA strain, we classify them as a cumulative mortality and morbidities. So these are the patterns where we have somebody had gone to group 4. This is a cumulative mortality versus those people who were in group 1 or normal LS strain values. And this is found to be very acceptability because this LS strain is much more effective value in people when we have a not clear-cut value of E2 prime ratios and other parameter of diastolic dysfunctions. And we divide them into 3 patterns. One is a filling, reservoir, majority of reservoir functions, and ejection fraction, where we look at these kind of things by speckle imaging. In which place are you working, Nida?
The Global Hospital, Parel, Mumbai.
Global. And who is a doctor over there?
Dr. Manish Jain.
Manish Jain. Okay. Is good, I believe then. Because very few people, even today, they talk about all these things.
Sir, it's a transplant hospital, so mostly we get across.
Now I
Yeah.
got it. I got it. Now why they're talking about all these things.
Yeah.
So because they are very afraid, and soon after transplant, they have to look at two important things.
Yes, sir.
Great. Any other question, Nida?
Sir, he asked me what is cirrhotic cardiomyopathy and why do we are much concerned about it.
Cirrhotic cardiomyopathy is why we are concerned about it. When we have a long-standing cardiomyopathies, it affects, leads to what? What will happen when long-standing cardiomyopathy would be there? It will be affecting your liver because the liver is at a constant flow, high flow of a revert flow.
High flow. Yes.
And when they have a very high flow of a reversal flow, the ultimately liver goes into cirrhosis.
Yes,
That's what is cirrhotic cardiomyopathies. Dilated cardiomyopathies with the elevated or not exactly dilated, any cardiomyopathy where the RV, RS systolic pressures, they are very high, they go into this kind of a pattern of cirrhotic cardiomyopathy. So number of times cirrhosis, they are in turn the presentation of heart conditions.
Heart.
And I'm sure like you will be learning a lot with Dr. Manish Jain. Your two questions were very valid, and normally we do not talk about all these questions in level 1, but they are valid questions for level 2, level 3.
Thank you.
Anything else, Nida?
No, sir. No. Thank you, sir.
Thank you, dear. Dr. Sai Prasad? Are you there, Dr. Sai? Dr. Manu Kapil? And last is Dr. Clay. Dr.
Yes,
Clement.
no question, sir.
No
Yeah, no
question.
question, sir.
Oh, you should have asked some question, man.
All the questions being answered, sir.
Yeah, got all the questions. Great. So
Yeah,
if there are no
yeah,
more
yeah.
questions, let me put end to this. It's a long session, almost 3 hours today. And I'm sure it must be very, very useful for all of you who have attended this session, and also useful to those people who did not attend the session. All right, with this few words, let me say, Dr. Dilip, you want to say something?
No, sir. No, sir.
Okay.
I just
With this word, let me say you stay safe, remain well, and see you next time, next Sunday, with lot of questions to all of you. So get ready with the question answer sessions. And I'll try to show you maximum clips so that it will be just like a Viva interview where I'll show you a clip and then I'll look for an answer. All right. And thank you very much. Good night, Shabba Khair, and you can have your dinner and whatever with your family. Enjoy and see you next week. Bye-bye. Good night.
night, sir.
Good night.
Good night.